Beautiful. Okay. I will go ahead and start talking. We may get a few more folks come on in, but that's okay. This is a topic that I think we're all decently familiar with. So wherever you jump in will be okay, and I think be able to effectively participate. Um, so this is let me get moved over here a little bit. All right. You think I would know how to organize my screen by now with Zoom, but here we are. Okay. So, good morning, everybody. Welcome. Today, I thought we would focus on a topic that I've thought a lot about, and I've tried to make some changes in my personal practice, but it's something that I hear come up a lot in EMS circles, not necessarily because people are excited to talk about it, let's put it that way, but because folks feel uncomfortable with it. In the times that I've been responding to calls in the field, I find that, as the doctor, I'm kind of pushed forward to have this conversation, which is reasonable, but not necessarily out of a sense of, oh, well, you're good at this, but a sense of we really, really don't want to do this, which makes perfect sense. So today we're going to be talking about how to tell someone that their loved one has died or pre-hospital death notification. This is a skill that is developed, and it's a skill that I think in EMS circles we don't get a whole lot of training on, especially given the amount of times we're asked to have this conversation. Um, Luckily, where I previously was as a fellow, we had both myself as a fellow and we had a person that was an emergency medicine trained palliative care fellow. So they specialized in having this conversation in the context of emergency medicine. And we came up with this kind of system of how to have this conversation together, and had previously made some training on it together. So this is kind of a compressed version of that training in a PowerPoint that I can fit inside of an hour. So um, this is something that I enjoy, well, not enjoy, but I understand the necessity of talking about and something that I do have a lot of thoughts and opinions on. So if you have further questions or, have specific things you want to talk about with this, then that's great. I would love to have that conversation with you. I'm also going to point you towards some other resources at the end if this is something where you're like, that was kind of a lot, and I feel like I need more information on how to do this more comfortably. I've got some places for you to go. So, that being said, let's go ahead and get started. So, as always, we're going to set it up with a case and we'll come back to it at the end. Um, you are going to be responding to a 68-year-old male in cardiac arrest at home. There's CPR in progress by the spouse. By the time you get there, they've been going for about 6 minutes already. There's unknown amount of downtime. This person was found down several hours after someone had last seen them, so we don't know how long they've been down. The death is unexpected. This was not a sick person previously. Their initial rhythm is a systole. After about 25 minutes of high quality CPR on scene, you've done airway management, you've done epi, you've completed all your protocols for that. There's never a change out of a non-shockable rhythm. It's always asystole, and you have no ROSC. So now there's a spouse and an adult daughter on scene, and they are frantic. They are asking, why aren't you taking him to the hospital? What are you going to do with him? What's going on? And now we're going to talk about how do we approach this conversation professionally and compassionately. You're doing a very high stakes resuscitation. You have an idea of how it's going to end. But now these folks on scene are getting pretty agitated and they need to be told something. What do you tell them? So today we're going to talk a little bit about why we terminate on scene versus transport. I think we're all pretty familiar with this at this point because this has been a thing for several years now. But we're going to talk about how families actually won't suffer harm from termination on scene. They actually tend to like it in the literature that we do have, versus the alternative of transport and further futile medical efforts. We're going to talk about compassionate communication strategies. So, what do you actually physically say to the people on scene when you end up in these scenarios? And then we're going to talk about an actual step-by-step framework for stopping resuscitation and those discussions around that. So, again, I think we're all pretty familiar with this at this point, but transporting during active CPR is high risk for providers. If you've done it, then you know this inherently, right? You can't do good manual compressions in the back of a moving ambulance. And also, if someone hits the brakes even a little bit, you're going flying. Um, Now that we have Lucases, that risk is mitigated a little bit, but it's still not great. The Lucas can fall off, it can travel, it can do all these things. Um, Having to get up and move around and maintain it is an issue. Also, driving lights and sirens at any point is a more elevated risk to both you and the public around you. It causes higher rates of crashes, all of those things. So, to the point where some systems are driving without lights and sirens for CPRs because they've already made the decision to transport them and it doesn't save a whole lot of time. So they just don't do it because it's a higher risk. Um, Again, the Lucas can sometimes mitigate this, but it's not really perfect as a system. So let's talk about this is actually somewhat convenient because, the AHA guidelines, for whatever they're worth, are mostly geared towards in-hospital cardiac arrest care. A lot of them are kind of wild when it comes to out-of-hospital cardiac arrest. But there are some of them that are very, very useful to us. And this was in the 2025 update that just came out that there's been lots and lots of noise about that's outside of the scope of this conversation. But they finally added out of hospital cardiac arrest termination guidelines. And they're quite strong. They're stronger than most of the recommendations in this. The current recommendations from the AHA, which everyone will ultimately follow, is a class of recommendation level 1 and a B level of evidence that EMS systems should be prepared to perform termination resuscitation on scene, including death notification training for EMS professionals. So notice the second half of that sentence. We should know and be trained on how to provide death notification to families. And then below that, prioritizing on-scene resuscitation focused on achieving sustained ROSC prior to initiation of transport for most adults and children experiencing out-of-hospital cardiac arrest can be beneficial in the absence of special circumstances. We'll talk about those special circumstances in a second, but just so you all know, if you're not familiar with these charts, core is class of recommendation. 1 is the highest level. That means that it's thought that the benefit of this thing extremely outweighs the risk of this thing. So terminating on scene has such a high benefit versus risk of, potentially not resuscitating someone that could have been, that it's a class 1 recommendation. And 2A is just below that the benefit very likely outweighs the risk, but there's not large trials. And then the LOE's level of evidence, the B-NR is telling you that it's a B level of evidence, and that there are multiple non-randomized and observational trials, but there's no randomized controlled trial. So our best level of evidence is randomized controlled trials. You can't do a randomized controlled trial on this ethically, so we'll never have A level evidence probably for this. This is as good as it's going to get, which is reflected in the fact that it's a level 1 recommendation already. All right. So let's talk about why it is a level 1 recommendation. Meaningful neurologic recovery after 20 to 30 minutes of CPR is exceedingly rare. If you are able to get a pulse back, your rate of having any sort of neurologic recovery after 30 minutes of CPR is like 1%. Some studies take it up to like 4 to 5%, but that varies wildly, and our best evidence is about 1%, maybe. It might be lower than that in reality. Overall, out of hospital cardiac arrest is about 5 to 7% survival, even in our most high performing systems. So 95% of people who arrest outside of a hospital are not going to have any sort of meaningful neurologic recovery, much less a survival to hospital discharge in any neurologic condition. It is lower when we exclude shockable rhythms and witnessed arrests. So, for those of you that have gone to one of the CPR trainings, I talked about those Utstein criteria cases, those ones that are most likely to survive. Those are witnessed, shockable rhythms, bystander CPR, all the factors working in their favor. If we take those out of hospital cardiac arrest, survival is like 1 to 2%. It's very, very low. So the majority of cases are taken out by taking out those most likely to survive. And all of our evidence so far supports avoiding non-beneficial prolonged resuscitation because all it does is kind of traumatizes the family more so and also exposes everyone involved to further risk. Whether you're in the hospital or out, you know, there's sharps, there's the physical trauma of caring for somebody in cardiac arrest, there's the transport risk. There's all kinds of risks that come with prolonged fetal medical care. Intra-arrest transport compared with continued on-scene resuscitation actually showed that intra-arrest transport was less likely to result in ROSC. There was a big study from the ROC, which is the Resuscitation Outcomes Consortium. That's a huge group nationally that does a lot of these big studies you hear about. And they did an observational study to look at systems that were still transporting immediately during cardiac arrest versus working on scene. They actually found that the ones that stayed and worked on scene had a higher ROSC rate than the ones that transported. It was 4% versus 8.5%. So working on scene doubled the ROSC rate in these cases. And this was a massive trial. This is where most of the evidence for that level of recommendation on that last slide comes from. So, transporting during CPR, except in certain circumstances, may actually be harmful to survival. A lot of people get nervous about that when it talks about, going to the family and interacting with them because you're gonna, be working somebody in front of their family and all those things. But it's actually better for the patient. You're gonna have their best shot if you work them on scene. I keep saying certain circumstances. Those circumstances are if you have a refractory VFib patient, somebody's got a shockable rhythm over and over and over and over and over again that's not converting when you shock them. They may be an ECMO candidate in some systems. We do not have reliable access to ECMO in our system, but those refractory VFibs, those refractory shockable rhythms, if you call med control, we may still consider transporting because there's other drugs and things that we have that you might not be able to do in the field. So those cases are the ones that you'll probably run into where we're saying, well, I know it's been 20 minutes, but we might still be able to do something. And it's very difficult to terminate on a shockable rhythm. Um, the other one is if you have somebody that's in a PEA arrest, so they still have occasional heartbeats on the monitor when you look at it, but it's not a shockable rhythm. So the AD will read don't shock, or the AD will read no shock advised because it thinks you have a pulse back. If you have what's called pseudo PEA, so those cases where there's no palpable pulse, but you're looking at the monitor and you're seeing heartbeats and it's fast. That means that there might actually be a heartbeat. They just might need different medicines to help their heart contract harder so that you can actually feel it. So there might be cases, but usually in those cases, it's going to be a PEA rhythm or, no pulse palpable, but beats on the monitor at like 80 or 90 or 110. It's going to be a normal heart rate or a fast heart rate. So those are not things that we would normally run into without having like an ALS crew and a monitor on scene. Those will be pretty obvious, and most of them are trauma cases. Questions about that? Perfect. All right. So, all of this together, where does this leave us? That puts EMS providers in the position of having to have a death notification conversation that just 10, 15 years ago, nobody was doing this. Everybody was transporting every single cardiac arrest. And now we're in the sudden position of having to have this conversation that we've never really had to have before. Um, all of you are passionate, empathetic people. You all have an idea of how to have this conversation inherently, I think. But because you are compassionate, empathetic people, and that's why you got into this line of work, I think there's a lot of anxiety that comes with that, right? I certainly have this anxiety every time I have to have this conversation of like, this is a big deal to this family. They're going to remember this moment for the rest of their lives, and how they process this grief is going to be colored by this moment. And that's a lot of pressure, right? You don't want to mess that up and potentially make things worse instead of better if you possibly can. But even in the EMS context, now you don't have a whole team to hand over. When I'm in the hospital, I can say, you guys keep going. I'm going to pull the family aside and have a conversation. You don't have that luxury most of the time. So now we're having this conversation in a less than ideal spot and scenario while ongoing resuscitation is happening outside of the hospital. So all of these recommendations are suddenly saying EMS provider training, EMS clinician training is a level one class B recommendation. Why is that? Well, there was actually a big survey that was done. It was presented at the conference that I just went to, so it's fresh on my mind. But they did a big survey of a couple thousand EMS providers and clinicians at all different levels. And 86% of them said they had given a death notification at least once in the last year. And these are systems of all different sizes. So, regardless of size, 86% of them said they had told someone that their loved one has died or that they were going to stop CPR in the last year. Over 40% of those EMS providers that had done that had never had any training on how to have that conversation. So, it was like 42% of them were doing what they thought best, but had no training on how to do it. Um, and then even those that had had training, this is a fun, 96% of them wanted additional training. So even the ones that did have training, all of them wanted more training. They still felt unprepared. And here's the part that I want to make sure that we're focused on as a system. 54% of respondents reported negative sequelae of feeling unprepared to have this conversation. And the things that they asked about were intrusive thoughts, lost sleep, emotional difficulty, the depressive symptoms, anything like that. So there was 54% of these responders who could draw a direct line between feeling unprepared to have a difficult conversation and having intrusive thoughts, lost sleep, emotional difficulty, or dysregulation. That's a huge deal. So that's a risk in and of itself when we talk about risks to providers of all these things. That is a risk that is involved in this context. Now, one of the things that I heard the first time we were going through, and I was talking with our palliative care doctor, and we were talking about, how to train folks to have these conversations, was I sent out my own little survey at our agency, and the biggest response that I got was, I don't want to be the person that this family remembers. I don't want to be the person that tells this family that we're going to stop. Um, I don't want to be the person that says we're not taking them to the hospital because they're dead and there's nothing more we can do with them. Um, People are going to get mad at me. Like I'm going to get punched in the face, you know? Which is a reasonable concern in a lot of cases. I've felt that many times. But here's the thing is kind of counterintuitively, families actually really, really value this person. Families really value honesty and clarity at the end of their loved one's life. So, whoever's on scene, they just want to know something, right? If you all have ever been in the scenario where you've had a sick family member or something really, really terrible going on, if it's, a natural disaster or anything, the thing that you most crave in that moment as a human being is information. That's all you need to know. When people are so stressed, all they want is to know the information so they can deal with it. And they will deal with it, but they can't until they've been informed of what's going on in a clear, concise manner. Um, Most people and their family members value avoidance of prolonged suffering. When you ask anybody, virtually every single person you ask will be like, oh, yeah, well, I would maybe want to be on, a ventilator or maybe want to be intubated or maybe want CPR, but only if I'll wake right back up and only if I can, go back home to my family and only if I can wake up and interact with my environment. I don't want you to keep me on life support forever. That's the most common answer I get is when I'm having these conversations about, do you want us to do CPR on you? They're like, well, only if it's going to work, right? So most people inherently value not prolonging their suffering, and their families would agree. Um, Both families and EMS providers highly value avoiding an undignified or unnecessarily prolonged death. So everybody's really on the same page here, is the takeaway. And if we can compassionately and clearly tell folks what's happening to their loved ones, it actually does make long-term coping easier. People are surveyed, days, months, years out from when their loved ones have died, and they actually have some literature on this that the way that this conversation goes, if it goes well, can actually affect their grief cycle and recovery. So you can actually help people do better and feel better if you have this conversation correctly. Okay, so I've talked a whole lot about, the importance of this conversation and all of these things. How do we actually tell people that we're going to stop CPR? What do we actually say in that moment? Um, does anybody here have like a phrase that they like to use or anything that they want to share of like, there's specific things that I like to say or I have a phrase? It's okay if not. I have my own, but I'm curious.
This is Josh here. A couple of the points that I was always told is use the patient's name and use the word dead.
Yes, 100%. Those are two very, very big things. Okay. So really, we're not super comfortable having these conversations, right? But we are super comfortable with procedures. When I was taught how to do this conversation in residency, they taught it to us like a procedure. They said, lay out your scene just like you would if you were putting in a central line, put out all your stuff, make sure you have all your equipment, make sure your space is prepared, make sure your other patients are tucked away for the time being. Tell everybody you're headed in to do this procedure so that they don't bother you. And then, put your phone down, all those things. And that was very helpful to me. So I think the same concept kind of translates. If you're going to put in a supraglottic airway, you're not going to open the patient's mouth and then just stare at it because you forgot to get out the eye gel, right? You're going to get all your stuff ready before you go to do the procedure. So this is the same thing. There's steps and there's an inherent order to this. So if you treat it like a procedure and you approach it like a procedure, then it's a little less freaky in my brain. So number one is still the scene preparation. Then, if you have the manpower, you're going to assign someone to do this procedure. You're going to assign someone to have this conversation specifically. This is a role in your CPR care team. If you don't have the manpower, I will talk about that in a second. You're going to introduce yourself and you're going to humanize everybody involved. This is where the names come in. You need to know the patient's name, you need to know the name of who you're talking to, and they need to know your name. You don't have to tell them your address and, your mother's maiden name, but you should tell them your first name. Um, and then we're going to do what we call signposting. We're going to put up a sign that's pretty obvious that tells the family, hey, we think this is going a certain direction. So they are not caught off guard suddenly. We're going to reassure them that we're doing everything we can. And then we're going to walk through the steps of what we're actually doing. Before we go to stop, we're going to summarize everything that we did. Okay. And then we're going to tell them what happens next, right? Because that's the most common question I've gotten on scene with these is like, well, what do we do now? Right? Are you guys just going to leave? What's going to happen? So, scene preparation, excuse me, ensure you're safe. You can't do any of this if you're not in a safe spot, much like you can't work a CPR if you're not in a safe area. Um, you can identify an appropriate location near the resuscitation, but not in it. You can acknowledge that there's a lot of emotional intensity. And I usually say something about this. And I'm like, I know that this is a very difficult time. I know that there's a lot going on right now. Can I talk to you for a moment to give you some updates? Just opening with that acknowledgement makes a big deal. It's kind of like, never tell a pregnant lady to calm down. This is kind of the same thing. You need to acknowledge that there's a lot happening right now. You should not say, "Hey, I need you to chill out and come over here," right? That's going to start everything off wrong. This person's loved one is dying. And you should, if you're able to, offer them the option to sit. This is going to be a hard conversation, right? If that person is calm enough that they can sit, it's always a good option and you have the space available. Some people do not want to leave the room. They will not leave the room, and that's okay. They can watch if they want. But I usually, when I'm having that conversation, kind of turn them slightly away. I'll position my body slightly away so they can focus on me and the words that I'm saying for just a second instead of staring straight at that, or else they're not going to hear anything you say. Okay? But let the folks kind of dictate what they're most comfortable with, right? Some people will be like, I got to get out of here and walk all the way into the backyard 100 yards away, and that's okay. Some people won't want to go that far, so just going around the corner outside of the door frame is totally fine. Some people want to sit down in the kitchen. It's all, they can have a little bit of the driver's seat on this. Just make sure that they're in a place where they can focus on your words. You're going to assign a dedicated communicator. So in prior systems, I've called this the family liaison. You can call them whatever you want, but you're going to have some single person be responsible for this. A lot of times it's going to be one of the EMTs on scene because if there's only one paramedic, they're going to be more involved in the resuscitation itself. If you're on a scene with, multiple medics, a ton of people, all those things, then it can be whoever is not actively involved in the resuscitation. There's always, if it's been going on for a while, if it's in town, there might be tons of people on scene. If there's only a couple of you, then that's, a little bit different setup. Um, a lot of times, especially for the folks that are not in town. So, like y'all up at Kendall, when I went up there and we talked about it, you're going to only have a couple of people at the very beginning of a CPR if you're lucky. So, the way that I handle this and have handled this, because believe it or not, when I was in the field briefly, there were more than one CPR call that I showed up to first by myself, which don't recommend you do, but especially as a doctor because you're useless. But um, you know, I would just say, get on, start doing compressions, and then say, "Hey, my name's Emily. I'm with EMS. There are more people coming. I will like stay right there. I will talk to you as soon as we're able." Some sort of thing of acknowledging them and that this is their, loved one. You're in their house all of a sudden, who you are, what you are, and there is more help coming. They may not know that inherently. They may just think that it's just you or just you two. So some sort of acknowledgement that that person exists and that they care about this person is very helpful. But then when they come on scene and there's more people, then you can physically assign them to say, hey, you go talk to the family. I think we're already pretty good at this in this system. I see this happening a lot already, but just as a reminder. Um, the communication role in these cases where you know things are probably not going to go as well as desired is just as important as the clinical role. Even when things are going well and you're expecting to get ROSC, you still really, really need somebody to be communicating with the family. Partially because they can get you more history. They can figure out what actually happened to the patient that you might not be able to do if you're doing CPR. But um, they're not going to tell you anything if they don't know who you are and what you're doing to their loved one. So the communication is really important. It helps me to think of the people on scene or in the ER that come in with the patient as this is kind of like a little mini mass casualty. These patients are going through an acute psychological trauma. And it helps me to think of them as patients also. Like you shouldn't leave them totally alone to deal with this. They are dealing with the fallout of a medical tragedy. So they kind of have their own right to be a patient in and of themselves. So you've set the scene, you've assigned somebody to talk to them. You're going to introduce yourself and you're going to humanize this conversation. We are really, really good at medicalizing these things. We're really good at separating ourselves from these conversations, and we refer to the patient in the third person. We refer to them as whatever. We don't even really, think of them as a person sometimes because we need to focus on what we're doing. And that's helpful when you're doing CPR, when you're doing acute medical care, but it's not helpful to the people that are watching at all. And in fact, it can really scar them. So I'm not saying that you need to say, give Jason, you know, 1 milligram of epi while you're running the cardiac arrest. But if you're the person that's talking to the patient's family, you need to know the patient's name. I'm really bad at names, so as soon as they say it, I repeat it back to try and like lock it in my brain a little bit. And then I use it every single time I refer to the patient. So I don't say he or she, I just say, you know, what did Jason do for work? When did you last see Jason? All those things. And so I'm using their name all the time. And you'd be surprised how comforting that is to families that they're just hearing their loved one's name. You should also know the name of the person you're talking to. You don't have to, use their name every single time. Like, Emily, can I get you a glass of water? Emily, do you want to sit down? Like all that. But you should know their name. Um, and you can say who's there because, for all they know, a bunch of people just rushed into their house. We had this issue in Dallas a lot where law enforcement responded to all these calls with us. So police officers would suddenly rush into somebody's house and they would get really, really scared that they were in trouble, that they were going to get arrested because someone's dead in their house and they don't know what happened. Is this a murder investigation? They don't know. So even if I didn't know the law enforcement officers' names, I would say, this is law enforcement. They come to all these calls with us to make sure that we're safe and to talk to you about next, whatever. But they come as a normal matter of course. This is not an investigation and you're not in trouble. Just that statement took the volume down a lot. So you can say, hey, you know, this is Josh, he's our EMS captain today. He's going to be doing this. This is our paramedic, and these are our EMTs. You don't have to give all of their names, but just knowing who these people are is very helpful. And tell them your name. I'm Emily. I'm going to be standing right here with you. We'll talk about what's going on. Now we're going to talk about signposting. I think this is the most important part of this process, right? So the thing that causes the family's most distress is all the suddenness, right? People who you show up on scene, and this is grandma is 109 years old. She lived a beautiful life. She's been on dialysis and heart failure with dementia for the last 20 years. And, she went to sleep peacefully and she didn't wake up. Those families are very, very different. They're usually prepared for this outcome. They may not even want CPR when you show up, and that's totally reasonable. But, you know, most of these calls we're going to be having this conversation is going to be someone who is otherwise decently healthy, and this was a sudden death that was totally unexpected. So these families are reeling. But the way that we mitigate some of that suddenness when we stop resuscitation is we tell them it's coming. You might think, a lot of people, when I mention this at first, are worried. They're like, what do you mean we tell them it's coming? Then they're going to freak out. It's like, no, they actually want to know what you're planning on doing and why. So you have to tell the family at some point before you stop doing compressions that you're going to stop. This is not always possible, right? If somebody shows up right as you're stopping, all those things. But if you have the availability, tell them well before you stop doing compressions that at some point you're going to stop. Explain CPR, right? Tell them we're going to go for 2 minutes and we're going to check every 2 minutes and see if it's working. After this many cycles, we get the idea that it's not working and we're going to stop. So you don't have to go into big detail here. What I usually say is something to the effect of, we're going to do compressions to help try and restart the heart. His heart is currently not beating at all. And in those 2 minutes, we're going to look and see what his heart's doing. If it's in a bad rhythm, but there's some electricity, we're going to reset it with a shock. If there's no electricity at all, we're going to keep going with the compressions and the medications to get some electricity back in the heart. And people understand that, regardless of their level of medical literacy. This does not have to be very detailed. One of the most fascinating little things that I read on this topic is there's a huge TV bias here. I don't know if you guys are like me. I have a really hard time watching medical shows. Like my roommate in med school was so into Grey's Anatomy, and I could not watch it because everything they do is so wrong. Like people are in the OR with their hair down, no masks. I can't stand it. But everybody else loves medical shows. Grey's Anatomy is like the most successful show on cable TV for the last 97 seasons. Um, in TV is where most people get their information on how CPR looks. And if you've seen TV CPR, then you know how inaccurate that is. Regardless of what they do during the CPR, there was a stat that somebody was published that like reviewed TV CPR. 75% of cardiac arrests get a pulse back on TV. So all these folks are expecting their relative to be okay. They think CPR works 75% of the time. And then they also studied how people get their information about CPR. Older adults, so those folks that, you know, probably never learned CPR, it wasn't around as much when they were kids, those folks that were more likely to be involved in this kind of care, like someone has a cardiac arrest in their house, 92% of older adults have gotten all of their information about CPR, nothing else, just from TV. So, as far as they know, CPR looks like TV. 92% of the adults that you run in, or the older adults that you run into, will know nothing about CPR except from TV. And on TV, it works 75% of the time. So they're not prepared for this to go south. They really aren't. They think you're going to show up and work miracles. So keep that in mind when you're having these conversations. And you need to set the expectation that if this does not work after this amount of time, we will stop. Because if people know it's coming, then they can deal with it. So this is a whole slide of a bunch of phrases that my palliative care colleague recommended. Um, so I say the top one mostly. So if we don't see a response on the monitor after 20, 30 minutes, we know that Jason will not be able to survive and we will stop resuscitation. That's pretty clear, right? We will not be able to bring him back after this amount of time. You can say other things too that are kind of supplemental. You can say, Grandma will not be the same person you knew before, even if we are able to get a pulse back at this point. She's very not likely to wake up. She's not going to be the same person. We can't survive after a long time without our vital organs working. We don't, the science tells us we don't show recovery after a long time of CPR. They're not going to get better. You can say it very plainly. Even if we breathe for Kathy, we need our heart to work by itself to be able to sustain life. Even if we breathe for, this is a lot of names to come up with, sorry. Even if we breathe for Tom, we need our hearts to work for our brain to function. Um, Despite all our efforts, medications, and shocks, our bodies cannot survive this long without blood flow or without our heart working. That's one that I use a lot. We've done all these things, but our bodies can't survive like this without our heart beating. We know after a long time, these interventions do more harm than good for Stacy. We're doing more harm than good after a long time. That's really, really powerful with families. After a long period of time, these treatments are not good for them anymore. They're not helping, they're doing harm. You can choose any mixture of those phrases, but I think it's useful to actually have a repository that you can pick from. So now you've set your scene up, you've pulled them aside, you've assigned somebody to have this conversation, you've learned their names, you know who you're talking to. You've told them, we're going to do this for a certain amount of time. If it does not work, we are going to stop. And you've been clear about it. But now the patient's family is like, oh my gosh, well, what are you doing to make it work? Like, you have to do something. So, this is where your reassurance comes in. So we're going to do these things. If they don't work, we're going to stop. Your next sentence is, we are doing everything we can to help patient's name. You might see us do all of these things, and here's what they are. And this doesn't have to be a long statement, right? This person is in acute distress that you're talking to. They're not going to remember the mechanism of action of medicines at this point. They just want to know what you're putting in or doing to their loved one. Mostly they want to know if they're suffering. They want to know if their loved one is suffering or not. So I say something like this. We're doing everything we can to help them. You might see us place IVs or IOs to give medicine. You might see us use electricity to reset the heart out of dangerous rhythms. You might see us breathe for your loved one with a mask or with a breathing tube if that's necessary. Some sort of, if you have a designated person available, having that person say, I will be with you every step of the way, really, really calms these folks. Some sort of assurance of, we're not going to disappear. I will be here. If you have questions, ask me. Tell me. Tell me what you're feeling. Explain what CPR is. A lot of people don't know. A lot of people think that, you know, in on TV, they shock non-shockable rhythms. So they might be confused why you're not shocking the patient. On TV, they do much shallower compressions because the person they're doing it on is alive, and an actor. So they might be like, oh, you're going too deep, you're hurting them. Like, why are you pushing so hard? You're going to hurt them. Explain that we're manually circulating blood around the body. Um, you can try to avoid as much medical jargon as you can. So don't say we're going to defibrillate them. Say we're going to correct any dangerous heart rhythms we see. People understand that. We're not managing their airway. We're giving them oxygen and breathing for them. Um, we're giving medications. We're reversing causes of cardiac arrest. So like if we're giving Narcan, those kind of things. Um, One of the things that came up a lot in prior conversations I've had about this is that families were getting really, really scared of IOs. The system that I used to work in went IO, you know, one shot with an IV, and if that didn't go, they went straight to IOs for cardiac arrest. Families have never seen that. Bystanders don't see IOs outside of the hospital. So when you pull out a drill and you start drilling into somebody's like arm or leg, they're going to be freaked out. And I've had families, you know, try to bat it away. Like they don't want that. And so you have to explain like this is the same thing as an IV. Your loved one is not aware of anything right now. They're not going to feel it. It's not really any more painful than an IV, although it looks pretty brutal. But they might need some prefacing, especially when you go to an IO if you're on scene for that. I like presenting CPR, like I said, as like a time-limited trial concept. A lot of people understand like trying something for a little bit and then if it doesn't work, moving on. So I say every 2 minutes we'll evaluate. If there's no response, we'll keep going um, for this many cycles. If there's no response after this many cycles, then we know that what we're doing is not working and we've reached the limit of what we can do. And I really try to use the phrase like we're doing more harm than good. We are prolonging suffering. We are not bringing them back at this point. So you've told them that, there's a possibility that we don't get them back, and you've prepared them for that. You've signposted and said, here, this is what's going to happen. You've reassured them of all the things you are doing. It's really important that they know everything you're doing to support that patient. When you've made the decision that we're going to terminate, we're not going to transport this patient, um, you're going to summarize everything that you've done. Families need to know and desperately want to know that you've tried everything, right? Especially if this is an unexpected death like our case. So before you stop resuscitation, summarize everything you did with the people there. Again, this does not have to be medical. You're not going to say, we have an ET tube, 7.5, 21 at the teeth, right? We're not going to do that. We're just going to say, um, we've tried medications, we've tried manually beating the heart, we've tried electricity when the heart's in a dangerous rhythm, we've tried breathing for the patient with, 100% oxygen. We're not seeing any response from, I'm picking on Jason, we're not seeing any response from Jason's heart. It has not started beating again on its own, despite all of these things. So you have to be clear that we have tried all these things and that patient's heart is not responding. Um, so you're going to say, we are going to stop. Very clearly, we are going to stop. And then you're going to pause before you stop and you're going to be ready for that emotional reaction because it's going to happen, right? You would if you were in that situation. You want to be clear when you deliver the news. If they have not grasped the fact that their loved one is dead in this moment, which a lot of people, when they're doing CPR, don't consider the person dead, then you need to use the word dead. You can say, despite all of these things, they remain dead. They are still dead. You can use it. That's not going to harm them by using that. People use phrases like past or no longer with us. People will be very confused by that. I've heard one of my co-residents said no longer with us at one point, and the family said, well, what happened? Did they go to the ICU? Like, did they move them? Where did they go? So you don't want to open yourself up to interpretation like that. Be very clear, right? Um, and there's been some studies on this, especially in the pediatric population. The families actually appreciate seeing resuscitation as it happens. So they usually believe you when you say you're doing everything. But seeing a whole group of people do everything all at once and see the amount, the Herculean effort that goes into resuscitation actually really helps families process the fact that everything was done and it's time to stop. Um, it seems pretty brutal. Like our natural instinct is to try and get the family away from the patient, to try and get them out of the room so they don't have to watch. But it actually helps with grief processing if they get to watch a little bit. Not everybody's going to want to do this, right? Some people have want nothing to do with this, and that's okay. But if the family member wants to watch, that's okay. I always kind of pull them aside, have this conversation of we're approaching the point where our all our treatments that we've done all these things, they're not working. We can't restart their heart. So we're going to stop. Would you like to go in and see what we are doing? Would you like to see this? I will walk with you. I will show you what we're doing so you can understand if you would like. And most of them say yes. Um, and if they say no, that's okay. But you got to read the room a little bit on this one. So here's some language so you have some samples for this. Despite our strongest efforts, we're not seeing his heart respond. That's pretty clear, right? Um, and then you can say, after this amount of time, medical studies show recovery is no longer possible. That's a little wordy, but some people want to know like why you're doing what you do, and just saying like there's science behind this helps. Um, Continuing these efforts will not help them. We are doing harm. We are not helping them anymore. That's pretty clear. Even with all the medicines, shocks, breathing tubes, etc., we've seen no response from them. These medical things are no longer good for them. That's a huge phrase. These are no longer good for them, so we are going to stop now. That's usually what I say. So what if you get in a situation where you can't do that signposting, right? You came on scene, there's only two of you, nobody else shows up, you have full hands on deck the whole time. This is where you have to have this conversation all at once in a very compressed fashion, right? So there's a couple of different acronyms that exist for this. And if you're an acronym person, if you're a mnemonic person, fantastic. I'm not really because I need to know the why, not I can't memorize mnemonics because then I just forget the mnemonic and what it stands for. But if you are a mnemonics person, these are a couple. So the one that I was taught in medical school that's from the doctors is called spikes. So it's very similar steps to what we just talked about. Set the scene. What I do like to do from this is what do they know already? So I'll usually ask something about, um, what do you know about what's going on with Stacy? Um, what uh what do you know so far? Or I don't I don't want to, you know, tell you something you already know. What do you already know about what's going on? And just a basic question, they'll tell you, like, we know this isn't going well. Or, they'll give you kind of the history of what happened, which is very helpful. If you haven't had a chance to talk to the family at all, usually they'll say, I don't know. We woke up this morning, she didn't come down to breakfast. And when we walked in, she was like totally unresponsive on the floor. And that's your history now. So it's helpful. Um, Invite them to figure out what they actually want to know, right? Some people don't want to know all the details. Some people want to know every single detail. So, something to the effect of, I have some information about so and so. Um, some people, I will say, some people want to know every single detail of what's going on. Some people just want to know the basics, and some people want to know nothing at all. What would you feel most comfortable with me sharing? And they'll tell you. Um, and then you got to tell them what's going on. This is not working. We've been doing CPR, all those things we talked about. Um, the E just stands for emotions, so pause for emotion. That's very doctor coded. And then strategy. What's next? What do we do next? Does the medical examiner come? All those things. The EMS doctors came up with one specifically for EMS, which is AUSC. So assemble, understand, share, and close, which is very similar. Get everyone together. What do they know? What's their health literacy? Um, Share, which has the concept of a warning shot. So I fear I have some difficult news about Stacy. That's enough for a signpost. Even if your next sentence is, we've tried all these things, all this, you just don't want to jump directly into, hey, we're going to stop CPR because they don't know what's going on, right? So you have to give some sort of preface, even if it's one sentence about how this conversation is going to go so they can prepare. Okay? And then let some silence happen. Like people are just going to stare at you, and that's okay. That's probably what I would do in this situation. But it's uncomfortable if you're not expecting it. So expect big emotions, expect total silence, all those things. Um, and then say, can I answer any questions for you? You know, what's going to happen next? all those things. Who's going to come on scene next because other people are going to come. But don't speculate. Don't guess. That's not going to be helpful. If you guess and you say something wrong, the family's going to remember that. So after all that, you're going to guide the next steps. So you're going to explain if there's law enforcement coming on scene, you're going to explain, hey, you're going to see some police officers here. They respond to every death at home. Um, Nobody's in trouble. They're just the folks that take care of this function because we have to go see other sick people. So, you know, law enforcement, these police officers, if you know their names, you can introduce them, are going to take over from here. You're not in trouble, but these are the folks that handle this from here on out. And if the medical examiner comes to like physically retrieve the body, which doesn't happen as much anymore, but used to happen more frequently, just explain who that is and what they do, right? They're going to come, they're going to do, you know, just a quick look to make sure that, whatever. And even if the medical examiner takes the body, that person will still be able to have a funeral. That person will still be able to, get buried in wherever they want. Those are important things that not a lot of people know inherently. Because again, on TV, once the medical examiner gets the body, they're doing a full autopsy. They're, have complete control, all those things. They've seen too many like NCIS and Bones episodes. So they don't know that like this is usually a quick check and then they go back to the family pretty quickly. So explain that. Like we don't know how long they're going to take it, but we know it's, usually not that long and then you can make any arrangements that you want after that. So, in summary, our on-scene termination of resuscitation balances our goals of safety, our science-supported literature, and dignity for the patient and their family. Families do benefit greatly from structured and compassionate communication. Clarity and empathy in these scenarios, if you can clearly and empathetically express what's going on, reduces their long-term distress. They actually recover better from grief events if you can have this conversation correctly. And your name and your words are going to be remembered. So this is something that you want to practice because regardless, they're going to remember you. So you might as well have it be a positive memory. This takes a lot of practice and it feels really weird. I'm sure that all of you are already pretty darn good at having this conversation. And the only thing that really, would trip you up is the discomfort with having it. But the way that I get around that is actually physically making myself practice what words I'm going to say because you don't want to stumble over your words in that moment. So, what I've previously done is added them to CPR scenarios. So, whenever you're doing your quarterly CPR training, add one of the scenarios. You're going to have the conversation. Someone can fake being so and so's wife, so and so's mom on scene and practice having the conversation of we're going to, take this distressed family member and tell them that we're going to stop CPR. Whenever we practice CPR, even like TV has a bias, we have a bias that it works, right? We always bring the patient back. But in reality, that's not the case. So, on one of your CPR scenarios, assign somebody to talk to the family, assign somebody to be a fake family member, and try to have this conversation in real time. You'd be surprised how hard it is, like off the cuff. Okay. I know we're at time, so I'm going to skip this, but you know, um, going back to our initial cases, think about what you would say to that family. Think about the exact words that you would say about, you've come up on a guy that was walking around, talking, playing around a golf this morning, and is now unexpectedly dead, and his wife and daughter are looking at you. Think about what you would say and have that prepared a little bit in your brain. If you are interested in this topic, if you are one of the 96% of providers that feel like they need more training on this topic, I still feel like I need more training um, just to be safe. But There's plenty of resources out there for you. This is my favorite one because it was backed up by evidence and it's also free. This is the First Responders Behavioral Health Initiative. They have a couple of trainings on their website. Some of them are paid, some of them are free. This is one that is free. And it was produced with that survey that I talked about earlier. So you can actually look and say, and you can sign up. It's about 50 minutes long. So just about as long as this is. And it goes a little bit more into special case scenarios of what if it's a kid? What if there's not family on scene? What if all these things? So we'll post this recording and the slides so you can follow this link in the slide deck, or you can copy and paste that, or you can just go type in FRBHI and then Breaking Bad News in Google, and it'll be the first one that pops up. And then these are some references for further reading on this topic if you want to see the studies I'm talking about. I think they're all open source, but if you open one and you can't get to it, email me and I can send you the hard copy so you can read through it if you're curious. Cool. That's all I have this morning. Any questions or anything before we wrap up? Excellent. All right. Thank you everyone for coming. We'll post the recorded version in the slides so you all can get at all this stuff. And if you have any ideas for further topics or other ideas on how we can make these lectures more useful, please do let me know. I want to make sure that this is useful and helpful for all of you. And yeah, just in time for my cat to run in. Thanks, everybody.